be closing more early. I'll be closing exactly at 6 p.m. I'm traveling, so I have to finish up and so that I can prepare and then proceed. So I'll try to finish everything up as early as 6 p.m. so that we can all go and do whatever we have to do after here. All right, so let's continue or let's start. So today we are finishing up on the postpartum periods. Okay, after the woman is discharged home, or after the after postpartum period, we all know, right? I mean, is it 6 weeks or so, right? So the first 6 weeks or 12 weeks, after the person had delivered, what happens, some of the things that the woman is likely going to encounter once the person goes home. All right. So the first area of postpartum we're going to talk about is lochia, right? And last time I made mention of lochia, and I was saying that we're going to talk about it, the various type of lochias that we have. At least we all need to know. If you listen to Mackay, it says um a rubra. He gave very simple way for you to remember, right? So we all know that the fluid or the discharge that comes out from the uterus after delivery of the baby and the placenta, what comes out, okay, is what we call lochia. So it consists of blood from the vessels of the placenta site and that of some waste or some debris, okay, that comes together or mixed together. And so as the woman transitions through the postpartum period, the color of that discharge or that fluid, if you want to put it that way, but let's use discharge. The color of the discharge that comes out changes as time goes on. And if a woman is also experiencing postpartum hemorrhage, you know that the fluid the person will be, the discharge that will be coming will be in excess or will be too much, right? So look here, help us to know which type of discharge is supposed to be seen around what number of days, or after, let's say, 1 week, what should be the color of the discharge that the woman will be experiencing. Is it supposed to be bright red as compared to the beginning? So if, let's say, you have someone who had delivered and then after 14 days or 2 weeks, the person is still experiencing discharges that are bright red in color, it is not normal. That discharge is not normal. The person would need to report back or will need to come back for assessment. Possibly the person is experiencing PPH, right? So when it comes to look here, we have three different types. Okay. So we have rubra. If you want to remember, rubra is red. So rubra red. Okay, if you want something you can use to remember, very simple. Rubra has a red discharge or red color in terms of the discharge that is coming. So we say that rubra is bright red discharge that occurs from the day of birth up to day 3. So from day 1 to day 3, the discharge is called rubra and it has bright red um color. So the discharge is bright red in nature. And you should know when it is ending, which is day 3. So if it's more, it goes beyond day 3 to day 5, day 6, and the person is still having bright red discharge, it is not normal. The woman will need to report. Then we have serosa. So serosa is brown. Serosa brown, right? So serosa is brownish pink discharge that occurs from the 4th day up until the 10th day. So from day 4 to day 10, the discharge that is supposed to come should have a brownish appearance. Okay, not a bright red appearance. So if you are having a woman who is 10th day or 7th day postpartum, and the person is not having a brownish discharge and it is bright red, it is not normal. You need to report that to the healthcare provider. Okay. Then we have alba. And so alba, we say albino. Albinos are white. Okay. And so if you want to remember I mean, in terms of lochia, I mean, arrangement, the last discharge the woman is supposed to experience is um alba. And so we say alba is albino. Albinos are white. So we expect that alba will have a whitish appearance or a whitish discharge. Okay. So that is how it is. So as the woman transition or as the woman moves through the days, okay, then the color of lochia will also be changing. And so alba occurs from day 11 to day 14. And so after 14 days, that's after 2 weeks going, yes, the woman can still have some discharges, but the discharge should be reduced. And then even if the woman is experiencing the discharge, it should have, I mean, that whitish appearance. If 14 days the person is experiencing serosa, it is also not normal. It is questionable. You would have to report that. That is the essence of us knowing this. Now, not only knowing, we also need to know that if someone is having any of these locusts and then the smell is very bad, that we've learned about the color. And so if the smell is also very bad, it has a very bad a very bad odor. Okay. That also should tell us that there's probably infection. Okay. And so you would also need to report on the not only the appearance, you look at the amount, and then you look at the color, at which age or at which day, I mean day the person is experiencing that, together with what we call the odor, and that will help you to know that whether you have to report or not. Okay, so we don't want the woman to have this look here and then it will have a very bad smell. If the person is having very bad smell, definitely there is infection, either there is endometritis, which we will talk about very briefly, that will require you to report for possible antibiotics. So here, one, we should know when each of them is happening, when each of the lochia is supposed to happen, and when it happens, how long it's supposed to take for one to end, and then the other will proceed from there. And then the color is very important. We need to know what will be the appearance of the lochias, okay, or the various lochia that the woman is going to have. Okay. That is just briefly on lochia. So rubra is red, serosa is brown, then alba is white. I think it's very simple. The only thing that doesn't go is the serosa and brown. I mean, it doesn't really sound well. But rubra, R, and then red, so it goes. And then alba and white, it goes albino, as I said, for you to simply understand that. Any any question on lochia and what we need to know on lochias? Any question on lochia? Yes, as I said today, we are just touching on the various things that are left. So postpartum. Another problems during postpartum period is the emotional changes that women experiences after the delivery, of which you can be asked, okay. And so when it comes to the postpartum, some are due to hormonal changes, okay. And so during the postpartum period, the stress that the woman goes through, and then some, I mean, hormonal changes that also has to take place could cause the person to experience some form of emotional issues. Okay. And then one of them is postpartum blues, which is normal. So mostly women after delivery, sometimes because of, especially if you are a new mother and then you haven't had that experience before and it is your first time, you are likely going to be stressed up at a point in time. Your child is not sleeping or your baby is not sleeping. You are not able to sleep, sleepless nights, your baby is crying, and a whole lot. Okay. If financially or family support is also not good, it also brings about what we call this kind of emotional issues. So the first emotional issue we talk about is postpartum blues, which usually occurs from occurs 2 to 3 days, okay, or the first 2 to 3 days postpartum is where the mother is usually experiencing that. Like I said, it's your first time. You've not experienced that before. And so you have a new baby, how to take care of the baby. The baby is crying, you're not getting enough sleep. Within that few number of days before you adjust, it becomes an issue over there. So you start thinking, you become a little bit more anxious. The insomnia will set in, you cannot sleep. Okay. And it usually resolves by itself because as time goes on, you now learn on how to take care of the baby, or the mother learns on how to take care of the baby. And so it usually resolved by itself. It doesn't require admission and where you have to admit and probably bring in what we call medication, unless it worsens and the person doesn't get the needed support, and then the situation worsens. That is where it will ends up in either depression or psychosis, okay, of which we'll talk about very soon. So you have mothers who, after delivery, just within 2 to 3 days, will be experiencing some form of anger, some form of anxiety. They also cry up, for no apparent reason. Okay. And then they complain of having headache, fatigue. Like I said, from the stress of taking care of the baby can give you all these kind of issues. They become restless and then sadness. They can also become happy. So it alternates. At the point you see them become happy, of course, they have a new addition, a new baby. And then at the point, the stress of taking care of the baby can also make them to become sad, especially if they don't have that very good support system. When it comes to postpartum blues, like I said, it's a normal feeling that most women experience. So you just need supportive care. You just need to provide support for what you call the woman during this period. Supportive care, you client and family education on how they can take care of the baby, right? So clients and support, family education, and then ongoing assessment for worsening what you call symptoms. So we expect that within 2 weeks, the problem should resolve, or the whatever the woman is experiencing should resolve, and then the person get back to normal life. But then if the support system is not quite enough, is not adequate, and then the anxiety, the depression continues, okay, the crying and all that continues, the woman can end up in what we call postpartum depression. So this will occur within 4 to 6 weeks postpartum, and can even last up to 12 months within the postpartum period. Okay. And so when it comes to depression, if you've done what you call mental health, you get to know that in depression, the person loses interest in almost everything. Things that used to be more enjoying, things that a person used to like a lot. They start to sell their things, they start to become very sad. They don't want to eat even when you give them you give them food, right? And so this can also come about as a result of the hormonal changes as well as the stress that they usually go through. Okay. And so depression occurs. Look at when the postpartum depression occurs, 4 to 6 weeks. We said that postpartum occurs very early, usually within the first 2 3 days. They start experiencing this. We then it resolves by itself. But someone experiencing depression would definitely need some form of pharmacological intervention, as well as some form of psychotherapy to help them on how to cope. So over here, they experiences the anxiety, but the anxiety is not just a normal anxiety. It becomes very tense, right? Then they have appetite changes. If, like I said, if you've done depression, you get to know that when one is depressed, the person doesn't enjoy, so they can either have loss of appetite or they eat too much. And so most of the time, It is the loss of appetite. So they can either be eating too much or not eating at all when it comes to depression. So there's what we call change of what we call appetite or appetite changes. Then they cry, they are sad all the time. Nothing makes them happy, right? And then difficulty concentrating on making decisions. And so these people also tends to have difficulty making decisions because they cannot concentrate, right? And then they feel fatigue, unable to sleep, feeling of guilt. When you give them the baby, they don't want to even take care of the baby, right? And then they are irritable, agitated, lack of what we call energy. They are not able to do anything. They are not able to take care of themselves. Self-care becomes a problem. Eating becomes a problem, right? And then loss of pleasure in normal activity. That is one of the key, what we call key symptoms for people with depression. Loss of interest in pleasurable activity, things that they used to enjoy they wouldn't have the pleasure to do those things again. And then suicidal thoughts, suicidal ideations. And so on suicidal ideation, one of the things you need to know on suicidal ideations are that they start to sell their personal belongings. And so when you do depression and then you are looking at suicidal thought or suicidal ideation, one of the main things that you cannot forget is when the person starts to sell their personal belongings. The moment you are reading a question and the question is about depression, and then it states that the person sells or the person starts to sell his or her personal belongings, that should quickly click your mind that this person is experiencing suicidal thoughts. So let's say the person has a mobile phone and then the person says that I am selling the mobile phone when the person is depressed, or the person has won an award, and then that award is very dear to him or her. And you see that person giving that award out, either by selling or just gifting it to people. Know that that is what we call suicidal thoughts or suicidal addictions. You need to monitor that very individual very well for suicide. When it comes to management, it's supportive and then pharmacological. So they will need what we call their antidepressants, okay, to help them out. Because as I said, it's mostly as a result of what we call hormonal changes, dopamine, and then the hormones that controls what we call our level of happiness will needs to be boosted out by what we call our medication. So when we talk about pharmacology, I'll then go into most of the medications when it comes to psych meds. Then we talk about psychosis. So postpartum psychosis. So this time around, it is not depression. It is not depression. The person now starts to hallucinate. The person starts to have what we call delusions. Okay, abnormal behavior start to set in. The person now feels like he or she is the most important person among wherever she finds herself. At this point in time, the problem had transitioned into what you call a more psychotic symptoms. Okay. So postpartum psychosis can also occur in the postpartum period. It mostly occurs within 2 weeks postpartum, and then the severity and duration can also vary. You have symptoms such as break with reality. They tend to have delusions. They tend to have, false beliefs, okay, about things that in reality is not supposed to be so. And then they start to hallucinate. So in hallucinating, it can be tactile, it can be um visual, where they see things that are in reality, it is not there. Okay. Then they can start to hear things. Okay. That is auditory hallucination. And so when you have someone who had delivered and within just about 2 weeks, the person starts to hallucinate, the person starts to become more delusional. You should understand that that is postpartum, what you call psychosis. For psychosis, they will definitely need admission. We will not be able to manage them in the house because they, at the point, they become more aggressive. if the baby is not even taking over from them, or if the baby is not taking from them, they can even kill the baby along the line. So when it comes to psychosis, we don't just try to manage them supportively. We need to admit them because they are what we call obstetric, what we call psychiatric emergency. So this is emergency psychiatry. They need emergency psychiatric hospitalization together with what we call their antipsychotics or together with their medications. Generally, if someone is experiencing any of the postpartum emotional changes I talked about, either postpartum blues, postpartum depression, postpartum psychosis, when you are managing them, you have to make sure that you acknowledge their feelings. When it comes to mental health, I also do mental health. So maybe as time goes on, I also talk about mental health and what we need to know when it comes to mental health. We need to understand that when we are managing people with mental health, we need to respect them. We need to acknowledge their feeling and then demonstrate caring attitude towards them, right? You have to determine availability of what you call family and then other support system resources in the community, especially resources they can depend on, right? So determine availability of family support and then other support systems and then resources as needed. You have to encourage and assist the client to verbalize their feelings. You monitor the newborn for appropriate growth and that of development as expected. You assist the significant other and then other appropriate family members to discuss feelings and then identify ways to assist them to cope with that client's behavior and then assist the client's care as well. All clients should be assessed for depression during pregnancy and then in the postpartum period. It is very important that when you are managing a client who is pregnant, okay, during the pregnancy, you have to assess the support system. You have to continue to monitor your pregnant client to know whether there are signs of what you call depression so that it doesn't lead to what we call psychosis. And same thing in the postpartum period, we continue to monitor them for any of these emotional issues I've spoke about. And so that is on postpartum blues, postpartum psychosis, and then postpartum depression. We need to know psychosis, they will present with psychotic symptoms. They will present with hallucination. They will present with what we call delusions. They will be out of reality. They will panic as well. But then with depression, we know that depression is more of emotional issues. They will be more depressed. They will be more sad, loss of interest in activities and all that. Okay. Psychosis will demand hospitalization and then your pharmacological intervention or antipsychotics. Postpartum psychosis would demand supportive care as well as your your antidepressants, right? To help them with what we call their emotional issues. But for postpartum blues, as I said, it mostly resolved by itself, okay? And usually it is normal feelings that most women go through because of the stress that they go through in the early stages of what we call childbirth. Okay. That is on the emotional issues. Let's talk about urethral ectomy. If you have a question, you can bring it up. If you have a question, you have an input, you can bring it up. Ectomy, urethral ectomy. So here is where the uterus is not contracting adequately, right? So a poorly contracted uterus that does not adequately compress on the large open vessels at the placenta side. So we said that in the um what do you call in the postpartum period, after you've delivered your placenta, the purpose of contractions the purpose of contractions are to press on the vessels When they press on the vessels, they cause the vessels to constrict so that bleeding will stop. Okay. But it could have a situation where the uterus is not contracting adequately, right? And that could lead to what you call hemorrhage. This can involve the anterior, posterior, or both areas of the uterus. Main assessment you find in your question, if there is what you call uterine atony, is what you call bulgy. So they usually use the word bulgy. The uterus on assessment was bulgy, right? So a soft uterus noted on palpation of the uterine fundus should definitely tell you that this is what you call uterine atony. So now read your question very well. When you read, look at the stem of the question. Is it stated that the uterus is bulgy, the uterus is soft? Okay, the moment that comes in mind, you just know that this is what you call uterine atony. What are the things that you do when there is uterine atony? First, the moment you have to first to assess, and then the assessment is what I said that is going to be bulgy, soft uterus. Then you massage. Okay, this is where you have to massage. I think we met some questions yesterday also where they were asking about whether you massage or not. Okay. If the uterus is already firm, you don't need to massage because that might not be the cause of the person bleeding. But if someone is bleeding and then the uterus is soft, what you need to do is to massage. So massage the uterus until it is firm. Then another thing that can also cause the uterus to be displaced is when the bladder is full. So you need to also assess the bladder to see whether the bladder is full or not. And so if the bladder is full, you empty the bladder by voiding or catheterization if that is contributing to the uterine atony. Then you notify your healthcare provider. Okay. So you notify the obstetrician or the healthcare provider. If intervention do not resolve the atony, so after you've catheterized and then, or after you've massaged and catheterized, if that does not resolve what they call the uterine atony, then you can inform your healthcare provider about that. Okay. Because the cause might be probably a different thing that is causing the person to bleed. So notify the obstetrician or the healthcare provider if intervention do not resolve the atony, because this could be an indication of what we call hemorrhage, right? That is on atony. So uterine atony. Kindly, it is very simple. Interventions, massaging, emptying of bladder. Okay. Assessment you are going to see in your question. Uterus is soft or bulgy. Those are the words they like using. And usually they will tell you that the uterus is shifted to the side, it's deviated. Okay. And so those are the things that you will see in your question. That will help you to know that it is atony you are reading on. Any question on uterine atony? Any input on uterine atony? Before we talk about hematoma and then what you need to know. It's raining at my end. I'll try to speak up a little louder so you can hear. All right. Okay, so let's go into hematoma that will happen in the postpartum period. So in the postpartum period, hematoma can also occur. Hematoma usually occurs when you do forceps assisted birth. That is why I told you that forceps delivery, it's something that it causes a whole lot of complication. And so when you deliver a baby or you deliver using forceps, there could be injuries. Injuries can happen around what you call the vulva, and that could lead to what you call accumulation of blood within the tissues. And when you have a blood collected, okay, or blood accumulated within the tissues. That is what we call hematoma. So it's just like where you get an injury and then there's no visible bleeding, but you can see that there is some form of swelling where blood has been collected, right? Where blood has been collected under your skin. That is what we call hematoma. And this can also occur during delivery, especially when you do forceps-assisted birth. Okay, so hematoma is where you have localized collection of blood in the tissues and can occur internally involving the vaginal sulcus or other organs like the vulva. Okay, and so vulvar hematoma are the most common ones, right? And so around the vulva, because of the pressure from the delivery, and then if you use any form of forceps, it can also cause the tissues or blood to be accumulated within what we call the tissues. Okay, predisposing factors, I've already said that when you do an operative delivery with forceps and then injury to what we call blood vessels, okay, you can have small hematomas that will absorb by itself. And so for small hematomas, they usually resolve by themselves. And then we have large hematomas. And so for large hematomas, you might need to do some form of incision so that you can remove what they call the blood that had been collected. Hello, can you hear me? Hey, I don't know whether you guys can hear me.
Yes, we can hear you loud and
We
clear.
are loud and clear.
Loud and clear. Okay, it's really very
Yeah.
heavy in here. All right, thank you. So there is what you call another thing you can also do when there is large hematoma. I made mention of incision. You can also do evacuation. So you incise and then you take off the clots, and then location and ligation of what you call the bleeding vessels. That is stopping the vessels or the bleeding. You can also have what you call shock happening for large hematomas. So if the person bleeds a lot, or if the absorption of the blood in the tissues are very, excess, it can lead to what you call shock, or yes, and then so a hematoma can result in shock. So you have to assess to know the extent of the hematoma, whether it has affected the person's vital signs. There are tachycardia, there is what we call hypotension and all that, to be sure whether there is what you call a shock or not. And so on assessment, the person will complain of severe pain. So there's abnormal severe pain, not relieved with what we call treatment or comfort measures, right? And so for something like laceration, if someone gets a laceration, let's say you do episiotomy for a woman and then there is what you call laceration, right? For that one, you apply some ice pack and all that, it can relieve the pain. Okay. But for hematoma, because of the blood that has been accumulated within the tissues, sometimes with some comfort measures like ice pack and other things, does not resolve the pain. So they do complain of severe abnormal pain that is usually not relieved with comfort measures. There is also pressure because of the accumulation of what we call the blood in the tissues. They tend to have what you call pressure within the perineal area. Okay, it's just like when blood is accumulated, somewhere else, and then you feel that pain, that pressure over there, especially at night. Okay, you feel that pressure, like when you have a swelling or there is inflammatory process somewhere, that kind of pressure, you feel it in what you call the perineal area. Then it is also sensitive bulging mass in the perineal area with discolored skin. And so if you get what you call some form of injury and there is hematoma somewhere else, you see that kind of skin discoloration. The same thing happened when, let's say, there's someone experiences hematoma in the postpartum period. There's going to be some form of discoloration, skin discoloration around the perineal area, and then inability to what they call void. they will feel pain. So usually you would have to even pass catheter to help them or to empty the bladder. There's decreased hemoglobin level and hematocrit. They will be restless, especially when shock sets in. They will be restless. Then there will be change of vital signs. Shock, as I said, tachycardia, hypotension will result in it. When it comes to your management, you are managing pain, right? And so monitor client for abnormal pain or perineal pressure, especially when forceps delivery has occurred. Then you monitor vital signs, and then you monitor for signs of shock. As I said, you place ice pack, okay, or you place ice at the hematoma site. You administer your analgesics as prescribed, okay, your pain medication, mostly, yes, your analgesics, your NSAIDs because of the inflammatory process. You prepare for catheterization because we said that these people feel pain, and so voiding becomes a problem. And so okay, catheterization is there, and then IV fluids for replacement of lost blood product if there is what we call decreased decreased hemoglobin level. You might have to replace the blood. Then you monitor for signs of infection, such as increased temperature, pulse rate also increasing, and then WBC count also being elevated. You might consider what they call infection, administer what they call antibiotics, okay? Because as prescribed, if there is what they call infection, sometimes we also give it as a form of cover up for what they call infection. You prepare for incision and then evacuation of what they call the hematoma, as I said. So that is on what they call hematoma, and then how hematoma can occur in the postpartum period, and what to do for your client or your pregnant or your mother. This time on your mother, right? When the woman is experiencing what they call hematoma. Then let's talk about PPH. PPH, hemorrhage, and shock. So this is basically PPH. This is basically our PPH. We know that PPH occurs when a woman loses blood, right, after delivery. But then you have to know the amount of blood loss to know that it is PPH or not. Okay. So the amount of blood loss is what will tell you that whether it is PPH or not. The last time there was a question here, and the woman had lost 500 mils of blood, and I saw that people were going for, PPH. Know that the type of delivery also determines the amount of blood that should be lost for you to say that the person is having what you call PPH. So for bleeding that is greater than 100 mil or more after CS, after cesarean section, that is what we call, postpartum hemorrhage. So listen, we said greater than 1,000. So if someone loses 1,000 mil of blood, we don't classify that as what we call PPH. If the person had cesarean section, it should be greater than 1,000. If it is exactly 1,000, it is not PPH if it is cesarean section. However, for normal spontaneous vaginal delivery, the woman should lose more than 500. Okay, the blood loss should be greater than 500 mils. That is the estimated blood loss should be more than 500 mils for you to say that the person is experiencing postpartum hemorrhage. So note the difference between the two. Cesarean section is more than 1,000 or more than 1 liter. Then for what we call normal spontaneous vaginal delivery, it should be greater than 500 mil, right? So greater than 500 mil is what we term as, that is when it is vaginal delivery. That is what you can term as PPH or postpartum hemorrhage. Or a 10% drop in the hemoglobin and hematocrits from admission to post-delivery with symptoms of what you call hemorrhage. So another thing, apart from, let's say, using the amount of blood loss, is you using the hemoglobin level. So if there's what you call a 10% more than a 10% drop, okay, let's say the woman came with about 11 a gram per deciliter, okay, that is the hemoglobin level. Then after delivery, you do HB, and then the HB had dropped by 10% or more. That is also indication of what they call PPH. Okay, that is also an indication of what they call PPH. All right. With symptoms of what it, with signs and symptoms of hemorrhage, that could also be classified as PPH. When we're doing the stages of labor, I told you that the stage 4 is very critical because it is that stage that if the woman is going to experience what they call PPH, the woman is likely it's going to occur within that stage. So monitoring your woman is very critical at that point. Okay, that is why you have to do your monitoring every 15 minutes within the first 1 hour, then every 30 minutes the second hour, then the second 2 hours you do 1 hour each, right? Because if the woman is going to bleed and that could lead to PPH, it is likely going to occur within the first 4 hours after delivery. So PPH or hemorrhage, okay, postpartum can occur early during the first 24 hours after delivery. However, PPH can occur later. That is why we've done what they call lochia. So if someone is let's say 2 weeks postpartum and the person is experiencing lochia rubra, it is not normal because rubra shouldn't occur within after 2 weeks. You don't expect to see lochia. So you can have hemorrhage occurring later, okay, not within the 24 hours, the first 24, it can occur after the first 24 hours. Sometimes even 2 weeks, you can still have a woman who had delivered experiencing what you call, hemorrhaging. Okay, so early postpartum hemorrhage is within the first 24 hours, and then late postpartum hemorrhage is after or beyond 24 hours postpartum. Whilst postpartum hemorrhage can occur anytime during the postpartum period, the greatest risk is during the first 4 hours, okay, or the 4 hours immediately after delivery, as I said. And then the second greatest is within the first, what they call 24 hours. And so, like I said, if a woman will experience PPH, the PPH is going to occur within what you call the first 4 hours. Okay, that is where there's a greater chance that if PPH will occur, it will occur within that time duration. Then causes of PPH, I spoke about atony not long ago, that when the uterus is not contracting as expected, right? When the uterus is not contracting adequately, the purpose of the purpose of the uterus contracting is to press on what they call vessels to prevent what they call bleeding. And so if there is what they call atony or uterine atony, it puts the person at risk of what they call hemorrhage. Then there's laceration. And so if, let's say, during delivery, the woman had a cut, that cut could lead to the person bleeding, and that bleeding could lead to what they call hemorrhaging, or could lead to PPH, right? Then hematoma, we spoke about hematoma, and then retained placenta fragment. And so when there's retained placenta fragment, there could be something we call sub-evolution. Okay, and so sub-evolution can occur where the uterus is not returning to its normal size and then shape, right? And so that can also lead to the uterus not also contracting adequately, and that can also lead to what we call PPH. Obesity is also there, and so how would obesity? So you can track obesity together with let's say if the obesity leads to the woman giving birth to a baby that is too big, and then you deliver the baby, and along the line, let's say there is a tear, the person can also bleed, right? Okay, you have a question. You can either put it there, read it out, and then address it, or you can speak if you want to speak. That is Cooks. Cooks, say you have a question, you can unmute and talk.
Hello,
Yeah.
good afternoon, good evening.
Yeah, good evening.
Please, with the hemorrhage, you
Mm.
made mention of some values, right? But when you are answering, when you are doing the Q bank, normally they
Uh-huh.
don't put. Sometimes they don't put the values there. They just put maybe the client is soaked in some number of
Ah,
parts.
yes.
Yes. So how do you?
Yes. I spoke about this when we're talking about stage 4. When we're doing um um stage 4 of labor, I spoke
Okay.
about the number of parts. So usually they wouldn't, yes, some questions will give you what you call the amount of blood loss. Others will also, kind of trick you to know that within, so like I said, the greatest risk is within the first 4 hours. Okay, it's within the first 4 hours. So if within the first 4 hours or within the first 1 hour, the woman is changing pad, okay, if the pad is completely soaked, okay, that is why you have to do your assessment every 15 minutes within what we call the first 1 hour. So let's say within the first 1 hour, every assessment you do, that is every 15 minutes assessment, the pad is getting completely soaked. Okay, that should tell you that the woman is experiencing PPH. Okay, so they usually use that, like on assessment, woman had changed pad multiple times. Okay, within the first 1 hour, and then all the pads were completely soaked. That should tell you that it is PPH the woman is experiencing. So that is one clue that you need to know. That the number of times how frequent the woman is changing the pad, okay, also is a determinant that the person is actually experiencing what we call PP. So if it is completely soaked, okay, that is what you call a sign of what you call PPH. So yes, some of the questions will trick you. Put the they wouldn't put the figures there for you to know, but then they will describe the number of times that the woman had changed pad. Okay, and that should tell you that the person is experiencing what you call PPH. Any other question? Any other addition? Any other inputs? Thank you for bringing that out. Okay. So let's look at how you manage PP. So persistent significant bleeding. So this is it. I even had it here. So what you asked or what I just said is here. So perineal part is soaked within 15 minutes. So this is it. This is what I just said. So when you do your assessment and then the pad becomes completely soaked, okay, within 15 minutes, that is a clear indication that there is what you call PPH. So on assessment, look at the number of times that the woman is changing what you call the pad. Okay, so if we are doing your assessment and within 15 minutes the pads are getting soaked and you are changing it every 15 minutes, it's an indication that the person is experiencing what you call PPH. Then when the person loses blood, they are going to have restlessness. There's going to be increased pulse. Those are the early signs of what you call PPH or early sign of hemorrhage. Pulse rate will go up. There's going to be restless. And then rapid and shallow respiration, decreased blood pressure, cold, clammy skin, um, there's decreased urine output because the kidneys are not getting adequate blood supply, and there's what we call change in level of consciousness, okay? And then complaints of weakness, lightheadedness, and then some form of what they call dyspnea can also occur. So all these are things that could help you to know that a woman is experiencing what we call BPH. When it comes to our management, our intervention, we have to ensure patent airway, right? ABC. Ensure that airway is patent. You administer oxygen because of the blood loss. You have to administer oxygen. Notify healthcare provider. You stay with your client. If you need to inform healthcare provider, you get someone else to inform the healthcare provider for you. You have to elevate the legs to at least 30 degrees, right? So when it comes to hemorrhaging, just to help with what we call return of blood, okay, or cardiac return, okay, you might have to elevate the legs to about 15 degrees. Then you check the uterus, the cause of it. Is it atony? If it is atony, we say we massage. Then you can also administer your IV fluids, right? You administer your medications that could also enhance uterine contractions like oxytocin, like prostaglandins and all that. So largely, oxytocin is what will be given to enhance what you call uterine contraction. Then you provide IV fluids, ringers, normal saline. You have to make sure that you are using your large IV line. And so with IV lines, because the client is bleeding, if you have to choose the IV line to use for this kind of cases, you might have to go in for size 16 to 18 gauge IV catheter. So if you've done blood administration, they usually also ask questions, which type of IV catheter size should be used for blood administration, right? But it says that if the client already has size 18 in place, so the preferred one is size 18, 16 or 16 to 18, right? And so if the client already has 18 in place, no need to change to 16, okay? But these are, others also use 20. So sometimes we say the most preferred one is 18, right? But then if there is already 20 in place, I'm talking about blood, right? You can go in for your, what you call your 20, right? But the most preferred catheter size for blood, that is just by the way, I'm just adding that, a size 18, right? But then for management of PPH and that purpose, we use 16 to 18 so that you can, because you are going to administer large quantities of what you call or large volumes of blood as well as IV fluids. You need catheter with a very large size or volume so that a lot of fluid can pass through at a faster rate. Then you have to monitor vital signs. You insert catheter to monitor kidney perfusion and all that. You have to administer blood, as I said, emergency medications to also help stop bleeding. Probably you might have to give tranexamic acids and other medications to also help stop what you call the bleeding. Then you prepare for possible surgery or other emergency treatment or procedures. You record your intervention. You prepare to send a client to what they call critical care unit for stabilization and ongoing what they call monitoring. That is on what they call PPH, and then what you do for your clients when the client is experiencing PPH. Any question, any input on PPH and what we expect to know? Okay, so let's proceed. We are gradually getting there. The next thing is we are looking at postpartum period. Some of the things at least we need to know. Mastitis is another thing, very simple. In mastitis, some of the things they would like to ask, whether you know, is, I mean, how the breast should be taken care of. Should the woman stop breastfeeding because of mastitis? No, the woman should continue breastfeeding. If the woman cannot breastfeed, they will need to use breast pump to express the breast milk so the baby can, because the more the blood, the more the milk get accumulated, the more the woman will feel the pain, right? So as we know, mastitis can occur in the postpartum period, where you have inflammation of the breast or chest as a result of a blocked duct and an infection. Mostly when there are cracks on what you call the breast, and then you have bacteria invading the area, infection can set in from there. So mastitis mostly occurs during breastfeeding, okay, usually 2 to 3 weeks after delivery, but it can occur anytime during lactation. Assessment, as we know, there's going to be localized heat, there's going to be swelling, there's going to be pain, and then tenderness, as well as swelling lymph nodes, right? And then elevated temperature, there's going to be complaint of flu-like symptoms. These are the things that you see in what we call mastitis. When it comes to mastitis, one of the things that you should encourage the woman is hand washing, right? So instruct the client in good hand washing and breast hygiene. Don't use a chest, but breast hygiene technique, right? How to take care of the breast. The last time I said that when it comes to taking care of the breast, never choose any option that says that encourage the mother to use soap to wash the breast. Okay. Never choose an option where it says that encourage. It's the same thing. What is the difference between chest and breastfeeding? It's the same thing. It's the same thing. Okay. It's the same thing. So I was saying that you could get a question where they are asking about how the breast should be taken care of. So if you get a question where the question says that encourage the woman to wash the breast with soap, regardless of the soap they mention, whether they state that mouth soap, whether they say what soap, never go for it. Okay, it is a trap. We don't use soap on the breast to wash. So you can just use lukewarm water if you need to wash the breast. When you are done, you dry it up, right? So you instruct clients in good breast hygiene. You promote comfort. So in comfort, you can use ice packs, or you can use hot compress or warm compress. Let me put it that way. So to also lessen what you call the pain. So apply heat. I don't want to use the word heat. Let's replace the heat by warm. So apply warm compress to the site, okay, as prescribed. Then you instruct the client that fluid intake should also be increased to about 2,500 to about 3 liters per day, right? Then you maintain lactation. So we don't tell the woman to avoid breastfeeding. Okay. So we maintain lactation during what we call mastitis. No, never go for an option where it says that a woman is experiencing mastitis during postpartum period. What would be the best education or the best instruction to the mother? And then you have educate the mother to avoid breastfeeding. Never go for that. So you encourage what you call breastfeeding, right? And then you encourage manual expression of what you call the breast milk, or use of breast pump every 3 to 4 hours. Okay. And so you have to encourage breastfeeding, even if the person cannot breastfeed. They will need to express the breast milk for what you call the baby. Okay. And then encourage the client, encourage the client to support the breast. So wearing supportive bra, it's also another thing. They shouldn't wear a tight bra. Okay, they should wear bra that is very supportive, and then they should avoid bras that are very tight on them. That could continue to put pressure on what you call the breast. Then you administer your analgesics as well as your antibiotics. Very important. If you have read, there's this, is it which kind of leaves do we use? Those who have done mastitis. When there is mastitis, what leaf can you apply to? That is on um um alternate management. They like asking that. So that everybody,
Cabbage.
they say that fresh cabbage leaves, right?
Cabbage. Yeah. Mm.
I don't know how that, what is the physiology? What did they say that it does to the breast? And clicks for you. So let us all know that during mastitis, they can bring you this, and you need to know that one of the things that you can use is application of fresh cabbage leaves to the breast. Okay. And then it says that yes, it works. So all right. So um someone probably had done it before. And so I'm sure it probably has some form of anti-inflammatory what do you call some form of anti-inflammatory effects, and that could help resolve what do you call the mastitis. So put that up at the back of your mind if you've not read it before. But as you are preparing for the NCLEX, you come across it whilst learning, and in your Q banks, you see it, that encourage the mother to apply fresh cabbage leaves to the breast, and that will help resolve what you call the mastitis or the inflammation. All right. Thank you all for coming in. Then we talk about
Hello,
some. Yes, hello, person.
sir. Please, I would like to ask a question.
Mm,
So during breastfeeding, like for the mastitis, and
mm,
then the mother experiences severe pain during breastfeeding, you say we should encourage the mother to continue breastfeeding, but not to discourage. So
yeah.
can we also give analgesic to, I mean, alleviate the pain? Because
Yes,
sometimes it
it's
becomes
part of.
so worsened that
Yeah, go ahead.
I said sometimes the pain becomes so worsened that, I mean, it's unbearable. So can you
Unbearable.
encourage the use of
Yes,
analgesic?
yes. I think
Thank you.
I just made mention of it. It's over here. Administer your analgesics. Of course, the pain is there. And so it's because of the pain that the woman is not breastfeed. The woman doesn't want to breastfeed, but she knows that when she breastfeed, the pain is going to be intense, right? The sucking and all that. So yes, you can give what you call your analgesics, okay, to help lessen what you call the pain, as well as giving your antibiotics along the line to treat the infection. Okay, so yes, you can give your antibiotic, but sorry, analgesics. Some of them will also take the analgesics, and then they will say that the breast milk is not coming anymore. Some says when they take para, right? I don't know if it's true though, but they will say when they take the breast milk production also ceases along the line. So yes, you can encourage what you call breast analgesics. Okay, you can give probably your brufen to help lessen what you call the pain. Okay.
Okay, thank you.
Yes. Any other inputs? Any other addition? Any other question? Then we talk about sub-evolution, and then how it occurs or how it can occur. So sub-evolution is very simple. It is when you have um, the uterus failing to return to its normal size and condition in the postpartum period. And the cause is largely when there is retained placenta, what they call tissues. The fragment of the placenta that is left behind can cause the uterus not to contract adequately. And so that could affect the uterus returning to its normal size. Infection is also another concern. When you have endometritis, and then you have, I mean, the inflammation of the uterine lining and all that, it could also affect the uterus returning to its normal size, and then some abnormal growth, like when there is fibroid or there is leiomyomas, okay, can also cause that. Then over distinction of what you call the uterus can also cause this, especially when there is what you call multifetal gestation, or when there is what you call twin gestation or multiple gestation. It can overstretch the uterus, and that could affect the uterus, the muscles of the uterus and all that. And so returning to its normal size and shape would be affected. When it comes to assessments, what you see in sub-evolution, there's going to be uterine pain on palpation. When you palpate the uterus, the client will feel pain. There's going to be, the uterus is going to be larger than expected because it has to contract and then return to its normal size and shape. But this time around, especially if it's overstretched, the uterus is going to be larger than expected. And then there's going to be issues of what they call hemorrhage because the uterus is not contracting adequately. And so there's going to be bleeding, and there's going to be prolonged lochia as well. Your management, you assess vitals because there's going to be bleeding and all that. So vitals are likely going to be affected. You assess the uterus and the fundus to know the size of the uterus. And then you also monitor for pain and then bleeding. Elevates what they call legs to promote venous return. And then you encourage frequent voiding. Okay. You monitor for your labs, your hemoglobin level, hematocrit levels, and then you prepare to administer medications that will enhance what you call contraction, and then presses on the small vessels to help with constriction. That is methylgonavir maltate, which provides sustained contraction of the uterus as prescribed. And so that is on sub-evolution. Very briefly, it is when the uterus is not, or the uterus fails to return to its normal size and shape, or normal size and condition. The cause, I've made mention of infection. I've made mention of when there is placenta fragments retained, when there is what you call some abnormal growth or tissue, abnormal growths like leiomyomas, and then those are the things that could cause it. I've talked about what you expect to know. Pain on palpation, uterus being larger than expected, the bleeding, prolonged lochia. Your management is largely centered on what we call bleeding and how you can stop the bleeding. That is on what you call sub-evolution. Then we talk about when there is infection. We said that infection can even cause the uterus not to return to its normal condition. That is when you have inflammation or infection within the lining of what you call the uterus. So endometritis, when you have infection of the lining of the uterus occurring in the postpartum period, okay, caused by bacteria that invades the uterus at the placenta site. The infection may spread. It may involve the entire endometrium and then cause peritonitis, and subsequently it can even lead to what you call pelvic thrombophlebitis as well. You could assess, because it's infection, so temperature is going to go up. It's going to be chills, it's going to be fever, then increased pause during infection, during inflammatory process. That is what we call increased pause. Then loss of appetite or decreased appetite, headache, backaches, all could happen. And then discharge, right? Lochia. I told you that when lochia is coming out and it has a very bad odor, it is an indication that there is what you call endometritis. Okay, so foul odor of lochia or reddish brown lochia, okay, it could be an indication that there is what you call endometritis. And then elevated WBC counts. Watch out for that. Definitely the WBC count is going to go somewhere about 17, 20,000. So when you're reading your question and it is endometritis, sometimes it's very easy for you to spot. First, look at, is a woman in a postpartum period? And then have they described the discharge that is coming out? Is it having a very bad odor? Then you look at the labs. Then you look at whether there's fever, whether there's chills, whether heart rate had gone up. These are all things that could help you to spot in your question that this is what you call endometritis in the postpartum period, right? So when it comes to your management, vital signs assessment, well, we said that temperature is likely going to go up. There's going to be what you call tachycardia. So you monitor for your vitals, very key. You place the client in what you call semi-fowler's position. This time around, you don't elevate the legs. We rather put the client in semi-fowler's. What it does is that it helps to facilitate the fluid or the lochia so that it doesn't continue to stay inside the uterus. So place the client in Fowler's position to facilitate the drainage of the lochia. You provide a private room for the client because of the infection. You inform the client that it is not necessary to isolate the baby. And then you have to instruct the client in proper hand hygiene, initiate conduct precautions, intake and output, you need to monitor, encourage food intake, antibiotics, very important. Then you also include some comfort measures such as back rubs, position changes, pain medications as prescribed, okay, and emotional support. You can also give medication to enhance with urethral contraction. So you can probably give your oxytocin to also enhance what you call. So I said that the private room possibly because of infection, right? And so that is why you have to initiate what they call contact precaution. And so if necessary, if the private room is there, you would have to isolate the baby, the mother, but not the baby from the mother. The mother can continue to take care of the baby, breastfeed and all that. But you want to isolate the mother. And that is how it's supposed to be. Okay. If the private room is available, just for what you call infection purposes. All right. So it's like when you are managing um the various infection control we did the last time. So if you have private room available, you can put the clients in what you call private room. You will ensure you are washing your hands. So it's just for the infection, okay? Uh-huh. Then we are almost there. I'm sure after this will be our last thing we're going to talk about. That is pulmonary embolism that can also occur in the postpartum period. So if a client in the postpartum period is complaining of chest pain, is complaining of difficulty in breathing after delivery, quickly start thinking, is there any form of embolism happening? It could be pulmonary embolism, right? Especially if the person underwent what you call cesarean section. There could be clots forming, the clots could travel through the vessels and then into the lungs, where it will affect what they call circulation and then gaseous exchange, and the person could go into pulmonary embolism. So pulmonary embolism is also another complication that could arise from in the postpartum period. Okay, that could occur in the postpartum period. So pulmonary embolism is where you have an embolus, okay, or a clot, if you want to put that way. And so passage of a thrombus often originating in in the uterus or other pelvic veins into the lungs, where it disrupts what you call circulation of blood. These clients will complain of sudden dyspnea and then chest pain. Okay, so they'll complain of chest pain. And you'll be wondering why just after delivery, in just after some few hours, the client is complaining of chest pain, client is complaining of, sudden dyspnea, quickly think about what they call pulmonary embolism, right? And there's going to be tachypnea, it's going to be tachycardia, cough, as well as some form of crackles on auscultation could be heard in what we call the lungs. They could be vomiting out blood. Yes. And that person, are you coming in?
Oh no, sorry.
All right. So there could be hemoptysis and then feeling of impending doom when things are getting out of hand. I mean, your management will be to administer oxygen very quickly. And so quickly put on client on oxygen. You have to elevate the head side of the bed. Okay. Could put the client in foulest position to facilitate what they call breathing. And then you monitor vital signs, um, respiratory rate, heart rate, and then breath sound as well. You monitor for signs of respiratory distress and then signs of increasing hypoxemia, reduce oxygen concentration, right, in the blood. Then you monitor for, you administer IV fluids and then anticoagulant. So anticoagulant, heparin, warfarin. This is postpartum period. We know that warfarin cannot be used, right? Warfarin cannot be used during pregnancy, but this is postpartum, so you can use your warfarin, right? But largely, probably they will give heparin just for the purpose of safety issues. And our last thing to do for this part will be thrombophlebitis, where you have clots happening within what we call the blood vessels and then leading to what they call inflammation. You could have partial occlusion of vessels. You can also have it's common. It most commonly occur in the legs, and then it can be superficial or deep or pulmonary. It can be superficial or deep. You can also have pulmonary embolism arising out of what you call thrombophlebitis. So when we did, like what we're doing, I think that was on cardio, and I talked about Vicos triad. So those who were here when I was doing cardio, I talked about Vicos triad, and I spoke about one of the causes or one of the components of Vicos triad is when you have venous stasis, right? Or we can also talk about injuries to blood vessels, which is part of what you call the causes of thrombophlebitis, where there's going to be injury to the blood vessels, and then the injuries could lead to blood clot forming, and then the clot could stay in what you call the vessels. They could travel and also cause the pulmonary embolism I just also spoke about, occlude what they call the lungs, and then leads to pulmonary embolism. There's increased blood clotting factors in the postpartum period, and that places client at risk of what you call thrombophlebitis. When it comes to prevention, we say that you encourage early ambulation. So that is why after cesarean section or after surgery, we encourage clients to ambulate as early as possible to prevent what they call increased clotting or increased blood clotting that could lead to pulmonary, or that could lead to thromboembolism and then subsequently thrombophlebitis occurring. On assessment, you can have what we call a palpable thrombus that feel bumpy and hard, okay, mostly in the legs, okay, around the thigh area. Tenderness and pain in the affected extremity is going to be warm and pinkish red color over the thrombus area. It's going to be some form of general body pains, chills, fever because of the inflammatory process, then diminished peripheral pulses, shiny white skin over the affected area, then pain, stiffness, and swelling of the affected extremity can also occur. You could have management depends on the location of what you call the problem or the thrombophlebitis. You can give your anticoagulant. Then you can also you have to assess the extremity for edema, tenderness, and any form of changes around the area, skin changes or increase in temperature around the area. You implement bed rest, encourage. Sorry, so this time around we don't encourage bed rest again. So I have to change this. So when someone is having thromboembolism, okay, thromboembolism, it's the thromboembolism that will lead to thrombophlebitis. When the clot forms, we encourage ambulation. It is no more encourage what you call encourage the client to sleep or to maintain bed rest. We encourage what you call ambulation as much as possible, but not a rigorous one. Because it says that when the client continues to remain in bed for a very long time, the clot will continue to develop. So as the client walks around, that is a form of energy that will help with what you call circulation, right? So that is it. It is not bed rest until what you call the symptoms resolve. Okay, but you have to encourage ambulation, gradual ambulation, as much as the client can tolerate. Then you can elevate what you call the affected extremities as well. You apply some form of, bed cradles to lift the weight of what you call the bed covers. Okay, so the bed sheets and the bed clothes off the affected legs. You don't want any weight on the affected legs that could cause the pain. You never massage. So in thromboembolism, we don't massage. Never massage the affected leg. When you massage, the clot could dislodge and then could cause pulmonary embolism. You monitor for symptoms of pulmonary embolism. I just spoke about difficulty in breathing, chest pain, tachycardia, tachypnea, and all that. Then apply hot packs. I usually don't like hot packs. I usually want to replace it with warm compresses because you don't want to cause pain. And so usually they like using warm compresses rather, and that could help as a form of comfort measures. It also helps with dilation of the blood vessels so that, whatever is there, circulation can continue. Then elastic stockings, right? And so the stockings are usually used after what you call the problem had been resolved so that it will prevent subsequent problems. But in what you call active DVT, when the clot is already there and then you apply the stockings and the stockings are like socks. They apply kind of pressure within what you call the vessels to promote venous return. And so when the clot is there and then they wear the stockings, the pressure from the stockings could also cause the clot to also dislodge. So the stockings are usually used after what you call the thrombus had resolved, right? And then you can put the client on what it calls stockings. Then you administer your medication, your antibiotics. Heparin also could be used as an anticoagulant. So heparin intravenously may be prescribed for femoral pelvic thromboembolism, thrombophlebitis to prevent further thrombus formation. Medication containing aspirin are not given to clients on anticoagulant therapy because aspirin also affects what we call clotting, right? So if someone is on heparin, don't go administer what they call aspirin as well because it could prolong bleeding time. So that is a take-home message. If you have a client who is on heparin and then they've prescribed what you call aspirin for that person, you would have to question what they call that kind of prescription or that kind of order. Our last thing will be client education on thrombophlebitis. We say never massage the affected leg or the affected extremity. Avoid crossing the legs and then prolonged sitting. Avoid using of constrictive clothing, right? And then anything that would cause pressure behind the knees. Know how to apply your stockings, okay? And when to apply stockings, you have to avoid smoking. You have to understand the importance of, the medication, the use of anticoagulants, and then other medication that have effect on what we call coagulation. We said that they should understand the importance of follow-up and then when to report to the healthcare provider. And so this will be the last thing we're going to do on the postpartum issues when it comes to maternity or obs and gynae for today. And then that will be the last part. It left with the medication, right? Then we'll bring that everything to a closure on this very topic. But before that, we'll go through our questions as we usually do. If you are not able to do the medication, Friday we'll finish that, and that will be the end of it. So before we do that, we have to do our questions. And then before the questions, if anyone also has a question, has a contribution the person wants to make, the person can make that contribution before we proceed on whatever we have to do next. Okay, so there's a question on the screen, eh? It says that the nurse is monitoring a client in the immediate postpartum period for signs of hemorrhage, which sign, if noted, will be an early sign of excessive blood loss. So we have A, temperature of 100.4, that is 38, and then 2, an increase in the pulse rate from 88 to 102 beat per minute. Then we have 3, blood pressure also dropping from 130/88 to 124/80, and then an increase in respiratory rate from 18 to 22 beat per minute. Yes. So that I see people answering already, right? See people going for option 2. That is, so what are we seeing? We are seeing tachycardia, right? And then we made mention that tachycardia is one of the early signs of hemorrhage. Early sign of hemorrhage. All right. Okay. Another question here. It says that why do we avoid soap and water? So the soap usually contains chemicals, as we all know. Is the soap is the soap is made of chemicals, and so the chemicals could cause crack on the breast, okay, which could also serve as an avenue or a channel for what you call infection or bacteria to invade the breast. So basically, when you use the soap on the breast and then it dries up, it usually causes cracks on what you call the breast. Okay. And so that is why we don't do that. All right. So I expected it would have asked that during the time when he must study it. So let's answer the question on the screen. So there's a question on the screen. And the question says that the nurse is preparing a list of self-care instructions for a postpartum client who was diagnosed with mastitis. Which instructions will be included on the list? Select or that apply. Wear a supportive bra. 2. Rest during the acute phase. 3. Maintain fluid intake of at least 3 liters per day. Then take prescribed antibiotic until the soreness subsides. The next one is continue to breastfeed or chest feed if breastfeeding or chest are not too sore. Then avoid decompression of the breast by using breast pump. Okay, so we have about 15 people, 17 people answering. Our mothers are going for 1, 3, 4, 5. 1, 2, 3, 4. Why? Okay. So 1, 2, 3, 4. All right. Um, interesting. Others are going for 1, 2, 3, 5. Okay. All right. So that is the final answer. So look at what is wrong with the fourth option. The thing says that take antibiotics until sourness subside. Do we take antibiotics until sourness subside? No. We complete antibiotics as scheduled, right? So the schedule regarding the antibiotics is what you need to follow, not until when the sourness subsides. Okay. Okay. The nurse is providing instruction about measures to prevent postpartum mastitis to a client who is breastfeeding the newborn. Which client statement would indicate a need for further instruction? 1. I need to breastfeed every 2 to 3 hours. 2. I need to change the breast pad frequently. 3. I need to wash my hands well before breastfeeding. Then 4. I need to wash my nipple with soap and water. Oh my God. I've already answered this in our previously. So if you close your eye, grandpa, you can answer this. So as for this one there, everybody knows this. All right. So the one who asks why we don't wash, you can read the rationale. You note that it stated that soap could cause dryness, and then could lead to cracking on the nipple, and so that needs to be avoided, right? Mm. All right, let's look at this. This is not on mastitis anymore. The nurse is assessing a client in the fourth stage of labor and notes that the fundus is firm, but that bleeding is excessive. Huh. Which would be the initial nursing action? One, record the findings. Two, massage the fundus. Three, notify the obstetrician. Then four, place the client in a Trendelenburg position. I like this. I like this question. Read details. Read the details of the question before you attempt. All right. I like that. I like okay. Okay. So kindly read the question, understand the question and what the question is saying and the demand from the question. The twos and the three, those going for two, those going for three. Why are you choosing two? Why are you choosing three?
Yeah, 3 because the fundus is already firm, but you can still continue to massage anyway, even though it's firm. The client is bleeding, so you can continue to massage.
Okay. Okay. So, I mean, the uterus is contracting. So the problem is sperm would not assist in controlling bleeding, right? So then the best and the first you can do in this instant is to quickly go ahead and inform the healthcare provider. That's why. So I noticed that others quickly went in for massaging because they saw that client was bleeding excessive, but they forgot that the question had stated that the uterus was already contracting adequately, or the uterus was firm by assessment. The uterus was firm. And so that was why I was laughing. I said, read the question. So you see, okay. someone, a client that is a primary porous client who delivered 4 hours ago. 2, a multi-porous client who delivered 6 hours ago. 3, a multi-porous client who delivered a large baby after oxytocin induction. And then a primary porous client who delivered 6 hours ago. Okay. So you guys are going for 3. Large baby, and then there was induction. That is fine. Okay. The nurse is monitoring a client's the nurse is monitoring a postpartum client who delivered 1 hour ago and received epidural anesthesia. I don't want to do this. I'll leave this for my medication. Okay, so that would have been the last thing we're going to do. But you understand it very well. We could still look into it. You would have understood it very well when if we had done medication, and probably I talked about epidural anesthesia, and then when someone takes epidural anesthesia, what are the main thing you monitor? And so um the nurse is monitoring a postpartum client who delivered 1 hour ago and received epidural anesthesia for delivery for the presence of vulvar hematoma, which assessment findings would best indicate the presence of. Okay, we're even asking for hematoma, right? Presence of hematoma. I thought it was that question regarding epidural anesthesia. Sorry. So this has to do with hematoma. All right, it's more of hematoma. And then we have changes in temperature. We have signs of heavy bruising. Then we have complaints of intense pain. And then we have complaints of a tearing sensation. I already showed the answer, but let's look at it. It says that which assessment findings would be indication would best indicate the presence of hematoma, changes in vitals, signs of heavy bruising, complaints of intense pain, and then complaints of a tearing sensation. I don't even remember the option I showed. Okay. So, you know why they are going for? They are going for the option one. Read the so this client had taken epidural anesthesia 1 hour ago. This client wouldn't experience pain. And so the pain is there is there to just as an um uh, uh, to distract you, because you know that someone who is experiencing hematoma would have pain. But remember, this client had taken epidural 1 hour ago, so we don't expect that. I mean, the epidural anesthesia will wear off just within 1 hour, and client will start experiencing intense pain and a tearing sensation. Okay. And then the signs of heavy bruising is not, but when vitals are worse, it's the vitals at this point that you can use. Okay. It's the change in vital. I don't know whether you understand the rationale very well. So the change in vital is what is going to help you to know that the client's epidural is worsening, or there is what you call epidural, sorry, there's hematoma, right? Because we said that when there is large hematoma, the hematoma can lead to shock where vital signs are going to be affected, right? And so in this very client who had taken an epidural anesthesia not long ago, you don't expect that client to experience that form of tearing sensation, that form of pain. Okay. So I hope you've picked something from this question. It looked very simple. I saw people going for three, that is the intense pain, right? But remember, this one had received anesthesia not long ago. So the intense pain shouldn't be a concern now, but rather temperature changes are what will be a cause for concern at this point. And so that is that for what we have to do for today. Fortunately, our time is up. Like I said, I'm also traveling. I need to set off, and so we would call it a day for today. The next week, Friday, we meet and finish with our medication. And so if we finish, I'll probably maybe do some brief pharmacology general, like I said, and then we will drop the curtain probably on my section there. And so if you have any question, you have any inputs you want to make before we end the section for today, you can bring it up.
Yes. Thank you so much for everything.
All right. Okay, thank you as well. All right. So that will be that